Next talk is by Dr. Dureja. Dr. Dureja is go.
Yeah.
If you finish early, then we'll have a question.
I will. 5 minutes. I've spoken enough now. So can we have the slide, please? Yeah. So I'll be talking about another important pathology, cervical facetal pain. And this is often a underdiagnosed cause of neck pain. I mean, we have a large number of population who is suffering from this because of injuries or because of other reasons, but generally it is underdiagnosed. And if you have patients with chronic cervical pain, almost 50 to 55% of patients may be suffering from this facetogenic pain. And of course, in our younger population, it is a major source of pain and disability and even socio-economic impact because they are not able to work sitting on a computer or other things. The anatomy, of course, all of you know that this is the joint supplied by nerve from below, nerve from above, as we were discussing. This is the branch from the dorsal ramus, and the joint has a capsule, joint has a synovium, so there is a synovial fluid too. Sometimes when you have a facet arthropathy, you can withdraw fluid, and there is an effusion, and just decompressing the joint gives a fantastic relief to the patients. And if it is persisting, then we knock off the nerves. As you can see, you are doing a radio frequency ablation of one above and one below. So, of course, I am not going into the detail, but this is the anatomy, that this is a joint from the superior and inferior, like we showed you in the live workshop. It's a synovial joint which has a capsule. So you should not be, the importance of this is that it's a very thin capsule. So intra-articular injections repeated should be avoided because you are disrupting the capsule. So median branch block would be a better option than repeatedly puncturing the capsule and causing injury and making the joint unstable. So it contains, the function of these joints is of course flexion and extension, and while limiting the rotation and preventing the vertebra from slipping over each other. The sensory nerve is the medial branch from the dorsal spinous rami. The typical presentation of a cervical facet joint is an axial neck pain. Patient will come and tell you that I get pain in this part of the neck. You ask him, it's radiating down? No, not much radiation, not radiation. Unilateral sometimes, very rarely bilateral. But of course, there is a limitation of extension. He says, as soon as I do this, I get a very sharp pain. And when I rotate my neck, also I get a very sharp pain. If you examine the patient, you may not find much except that if you are right on the facet joint, you may elicit a tenderness. And of course, whiplash injuries, sudden injuries in the car, and various other sports injuries can result in this. So it's an ipsilateral axial neck pain, dull pain, but the sharpness is only on movement. There is a referral pattern too, because the nerve supplies some areas. So I'll show you that C1, C2, C2, C3 can come up right in the ophthalmic, the occipital division of the nerve, and there are C4, C5 can even go up to the scapula. Secondary to trauma, sometimes we do not know, maybe bad posture, using big pillows can also lead to this. Typical morning stiffness, they get up with a very stiff neck, and they are very much worried because in the morning the neck is so stiff that they don't feel like getting up from the bed. And of course, extension and rotation results in more pain, and there are no neurological deficits, absolutely no neurological deficits. So this you can see the normal facet joint, and this is a diseased facet joint. We have osteoarthritis and various other reasons which could be cause of this degeneration of the facet joint, generally seen in elderly patients, like the arthritis of every joint. You can have misuse arthritis of this joint. Secondary to trauma, sports injuries, whiplash injuries. Secondary to inflammatory conditions, yes, we do get a lot of patients of rheumatoid arthritis and ankylosing spondylitis who keep complaining of pain in the one side of the neck, and that is because of the inflammation of the synovium. So this is more of an inflammatory. So in these conditions, probably an intra-articular injection of steroids would be better off than doing a medial branch block, because this is going to come again and again. And subluxation of facet joints due to spondylolisthesis is also one of the rarer causes. The pathophysiology, of course, the inflamed facet joint, the surrounding muscles go into a spasm. So it's a muscle spasm pain, Hypertrophy over a period of time can itself cause pain. Thickening of the capsule again can result in pain. And then degeneration, osteophyte formation, rubbing against each other, they can also be the cause of pain. So these are some of the pathophysiological factors of cervical facet change. It's often a clinical diagnosis. You may do MRIs, CTs, perhaps CT may give you some clue, or a bone scan can give you some clue, but who is going to get a bone scan for a neck pain? Typically non-radicular, as I mentioned, worse in the morning or during periods of inactivity. So you can see that painful extension and lateral rotation of the neck is generally the provocation for more pain, and if you do the simple test, you will find that the pain aggravates. Now this is what I was talking about the referral pattern, and you may have the pain referred to C2, C3 from the C2, C3 facet joints, C3, C4 side of the neck, the commonest presentation. C4, 5 can even go down to up to the scapula, and C6, C7 facetal pain can go right below the scapula too, and this is the area of C5, C6. So if you clearly take the history, they will tell you that it is referred, never on the trapezius or never on the shoulder like a radicular pain, but it is basically around the spine, so paraspinal areas where this referral pattern is seen, and by this referral pattern itself you can localize which particular facet joint has been involved. So that's the importance of a good history and good physical examination to come to a diagnosis, so that you confirm it by doing a dorsal branch or the medial branch of this particular. These are some of the morning we had discussed: differential diagnosis, myofascial pain syndrome, cervical radicular pain, cervical disc degeneration, and of course injuries. Clinical diagnosis: MRIs do not give any information unless there is a very severe arthropathy or fluid. Diagnostic medial branch is one of the gold standard approach to diagnose this. A simple test, I think tomorrow maybe we'll try to show you live, and you have to do 2 diagnostic blocks in order to go for a radio frequency at different intervals, and if both the 2 diagnostic blocks are positive, then you go for a radio frequency ablation. So we are now even doing radio frequencies, of course, one regenerative therapies. So if it's like a spondyloarthropathy, you can inject PRP solution into the facet joint, which is a regenerative therapy and really can help these patients. You should be aware of the anatomy. So this is what you get after squaring, and these are some of the structures. This is the facet joint, this is the articular pillar which we have to target. This is the place where the dorsal rami would be seen, and you have to target that. So important to see the structure, the facet joint, the lateral mass, the lamina, the spinous process, and this particular the articular pillar is the most important thing when you have to place your needle for radiofrequency ablation. This is a facetal joint injection. As you can see, the spread of the dye in the facet joints, and this is the place where you are going to do a diagnostic. So you right in the middle of the articular pillar, you place your needle, and remember you have to give very low quantity of local anesthetic. You don't have to give a high volume, one that it spreads to the root, which are very close. The root is just around. So you don't want to call it a root block, because there will be some motor loss and sensory loss, and in any case you will not be able to know whether it is pain relief because of the diagnostic branch or something else. So that is to be avoided. And then you do a radio frequency ablation. This would be the exact position of putting your radio frequency cannula. Do the stimulation as we saw in the morning. We do the stimulation, sensory stimulation up to 0.5 millivolt, 0.5 volt. If you don't get a stimulation in the arm, etc., that is a confirmed position. Motor, you will see the fasciculation in the muscles. And then you can do at different levels. This is the AP view, and this is the lateral view, where you are putting the needles on the middle branches, and then doing a radio frequency ablation. Thank you. Finished in 8 minutes. 7 minutes.
Question now.